Greetings. My name is Corbett Schimming. I'm a geriatric psychiatrist in practice in New York City, and I'm also one of the co-chairs of the IPA's Global Perspectives on Mental Health of Older Adults, a primer for clinicians, and I want to welcome you all. I hope you will find this program both intellectually stimulating and also practically helpful in your day-to-day work with patients, with older patients, wherever you may be practicing. So today I'm going to talk about a topic near and dear to the hearts of people caring for older patients with dementia, the so-called behavioral and psychological symptoms of dementia. And I'm going to specifically talk about pharmacologic treatment approaches. I should say also, I will be discussing off-label uses of medications in this presentation, as there are no FDA-approved medications for BPSD. Learning objectives are to both understand the symptoms themselves, the clinical presentation, and the repercussions of BPSD. Second, to describe the pharmacologic treatments that may be helpful for patients with BPSD and sort of present a review of the data on each of the major classes. And hopefully to describe a proposed sequential pharmacological approach to BPSD when non-pharmacological interventions are ineffective for patients. And I'll save that to the end, and I hope you find that interesting when we get to it. Okay, so let's get started with a case history that I hope will better illustrate the clinical problem that we're going to talk about today. So this is a 75-year-old man with no psychiatric history and a past medical history of hypertension, coronary artery disease, and type 2 diabetes, who reportedly has about 4 years of slowly worsening memory to the point where he started to forget to take his medications, started to make mistakes with their finances, and even started to get lost while driving. His wife took him to a neurologist who did some tests and a workup and diagnosed him with Alzheimer's dementia. But the reason she's bringing him to see you today is because of some very upsetting and even scary behavioral symptoms. He started to become irritable, which he's never been before, flying off the handle about little things with her, has expressed some paranoid thinking to her that people are stealing money from him, that perhaps she's been unfaithful, and has been intermittently agitated, and even has raised his fist to her several times when they've had a disagreement, to the point that she was worried that he might actually hit her. On brief bedside testing, his Fulstein Mini-Mental was 21 out of 30. He has 0 out of 3 delayed recall at 5 minutes and demonstrates both poor insight and judgment on exam. Current medications include lisinopril, metoprolol, metformin, donepezil, which was recently started by the neurologist for his memory, and an aspirin. So his wife asks you, doctor, what should we do? I really want to do right by my husband and care for him at home as long as I can, but I'm worried for my safety. So that's what we're going to talk about today. So let's start by defining the problem of behavioral and psychological symptoms of dementia. As many of you know, the DSM-5 revised the diagnosis of dementia to so-called major neurocognitive disorder with the most recent update. And major neurocognitive disorder, or dementia, is defined as evidence of significant cognitive decline in one of the following cognitive domains: memory and learning, language, executive function, complex attention, perceptual motor skills, and social cognition. These deficits must interfere with independence in everyday activities and not be the result of delirium or some other axis 1 disorder that would better explain the symptoms. So dementia is a major public health problem affecting about 44 million people worldwide. And as the population ages, this number is projected to expand to 76 million by the year 2030. In fact, there are currently about 5.8 million Americans living with Alzheimer's disease specifically. And it's a disease that expands rapidly as patients age. About 17% of people between the ages of 65 and 74 suffer with the disease, and approximately 36% of those ages 85 and older. And although we think of this as primarily a cognitive problem, patients very, very frequently develop associated behavioral, psychotic, and psychological symptoms as part of the disease. It's been estimated that upwards of 60% of community-dwelling patients will develop these types of symptoms, and well over 80% in institutionalized patients. The particular symptoms often correspond to specific etiologies, but there's considerable overlap. For example, delusions are more common in Alzheimer's disease, depression and apathy in vascular dementia, and symptoms and behaviors such as disinhibition and eating disturbances in patients with frontotemporal dementia. And as I said, although this is primarily a cognitive problem, these types of symptoms, the so-called BPSD, are often the most stressful and debilitating for both patients and caregivers. Okay, so let's talk about the range of symptoms themselves. BPSD includes emotional, perceptual, and behavioral disturbances similar to those that we see in other psychiatric disorders. However, the neurobiologic substrates are probably very different in these patients. I like to group the range of symptoms we see in patients with dementia into these 5 different categories. First, perceptual symptoms. This would include things like delusions, and very often these are simple delusions, not the more complex kind that we see in patients with schizophrenia. These are things like my loved one is cheating on me, someone is stealing money from me, why did you take this from me when the patient has actually just misplaced it. Patients can also have hallucinations, and this can be auditory, visual, or tactile. Second are motor symptoms. This can be pacing, wandering, repetitive motions, and even physical aggression. Verbal symptoms, yelling, calling out, repetitive vocalizations, verbal aggression. Emotional symptoms, things like irritability, easy agitation, disinhibition, apathy, anxiety. And vegetative symptoms, sleep changes, appetite changes. So what are the repercussions of developing BPSD? Well, we know that BPSD is associated with decreased quality of life in patients and may even portend a worse overall prognosis. It's associated with a more rapid cognitive decline, and some studies, although not all, even show that BPSD is associated with increased mortality. We also know that it's definitely associated with increased caregiver stress, and that caregiver stress itself is the biggest risk factor for early institutionalization. So patients with BPSD are much more likely to be placed in nursing homes or other institutional settings earlier. And it's also associated with risk of poor care, neglect, and even frank abuse at the hands of caregivers. BPSD is associated with caregiver depression, anxiety, anger, and social withdrawal. So a lot of repercussions for patients and the people caring for them. So when we drill down into more specific symptoms within BPSD, we know that agitation occurs in the majority of patients during their disease course and increases in prevalence as the disease itself progresses. Aggression, physical or verbal, is uncommon in mild stages of disease, but increases with disease severity. Psychosis, as I said, most commonly paranoid, simple paranoid delusions, occurs in about 20 to 30% of patients with Alzheimer's disease, but doesn't seem to change very much as the disease progresses, although psychosis is obviously more difficult to assess as patients become more and more cognitively impaired. And also, these types of symptoms tend to be episodic. Just because you have these types of symptoms now doesn't mean that you'll have them 3 months from now. So while we often don't know exactly why patients with dementia are developing these symptoms, I think it's helpful, and I try to do this in all of my patients, to think about the various contributory factors that might be leading up to them, both in the patient, in the caregiver, and in the environment itself. And then hopefully we can intervene on one or all of those domains to help ameliorate the symptoms. So first of all, in the patient, there are clearly neurobiologically related disease factors that are related to the development of these symptoms, although we don't fully understand them. We know that agitation, disinhibition, and psychosis in particular are associated with volume reduction and hypometabolism in dorsolateral prefrontal cortex, anterior cingulate, the insula, and temporal lobes. These are areas related to emotional regulation and self-awareness. Not surprising, as these are often disturbed in these patients. And also associated with alterations in cholinergic, noradrenergic, dopaminergic, serotonergic, and glutamatergic transmission. Apathy is associated with small vessel white matter disease. Also, sensory changes, changes in hearing, in vision, are often contributory. When patients can't hear, they may express themselves in an agitated or aggressive way, not being able to tell their caregiver that they simply can't understand what they're saying. Acute medical illnesses often cause or worsen these types of symptoms. Pain, often medication side effects that these patients are more susceptible to. Unmet needs within the patient, and I find this is to be a very common reason for people to develop these types of symptoms. Lack of social contact, lack of daily structure, lack of activity. Sometimes patients are hungry, sometimes they're tired. These basic human needs are often minimized or neglected in patients with severe cognitive problems. Sometimes premorbid and current personality or psychiatric problems in the patient can lead to these types of symptoms. And as I said before, very often caregiver factors can contribute to BPSD. When caregivers are stressed, when they're depressed, when they don't really understand the nature of the disease their loved one or charge is suffering with, when there are mismatched expectations. I think of a patient of mine where he has advanced Alzheimer's disease, and his wife expects that he should still be changing the oil in the car like he has for the whole of their married life, and that kind of mismatch between what the caregiver expects and what the patient can actually do given the realities of their disease. Sometimes the caregiver is reinforcing with these agitated or negative behaviors by giving the patient attention. Although it may be negative attention, they're still reinforcing these behaviors with attention when they respond to it. Environmental factors are often implicated here too. As I said, lack of structure in the patient's day, overstimulation with sound, too much light, too little light. These all of these things in the environment, and then cultural factors sometimes play a part. expectations vary amongst cultures as to what adult children and other loved ones should be doing. In some cultures, the expectation is that adult children will care for revered elders, and the tolerance for these type of behaviors may be quite different from another culture where adult children don't see the care of their older relatives as an expectation and may have less tolerance for them. So now that we've talked about what these symptoms look like clinically and described how common they are, and also talked about their repercussions, both for the patient and the caregiver, I want to move on to a discussion of the evaluation of BPSD. And to start, BPSD is really a diagnosis of exclusion. You want to make sure there are no causative or contributing factors that better explain the patient's symptoms before simply assuming that they're a result of their dementia. So the first thing the clinician needs to do is characterize the severity and nature of the symptoms, and part of that is doing a safety assessment. You're basically wanting to ask, can this safely be managed? Can this be safely managed at home, or would this better be evaluated and treated in an inpatient setting? And that includes patients who are so aggressive or so dysregulated that they are putting themselves or other people in danger, or patients who have some acute medical issue that's causing a delirium that needs to really be addressed and treated in a hospital setting. You want to get the caregiver to really describe specific behaviors and not just resort to generic terms like agitation or depression or anxiety. You want a specific behavior that you're trying to target so that you can know specifically when you've been able to treat it well. So this would look something like, every time I go to give my dad his medications, he slaps my hand away, something like that. You want to make sure you know about the onset of the symptom. Is it acute? Is it subacute? Is it chronic? Has it been there for a long time? Its frequency. Is this something that happens just once in a blue moon, or is it happening every day? And its timing and trajectory. Is it happening at one specific time of day? Like, is this typical with sundowning? Does it change over the course of a night, get worse, get better? All these are important. You want to make sure that you've reviewed the patient's medications. Have there been recent changes? Are they on central nervous, on medication with known central nervous system effects, things like antihistamines, anticholinergics, antidepressants, etc.? Is it possible they could be withdrawing from medications? Medication withdrawal, especially from antidepressants, benzodiazepines, or opioids can often contribute to BPSD. What about akathisia, a known side effect of neuroleptic medications? You want to make sure that you assess comfort. Things like pain, for example. We know pain is present in 46 to 56% of patients with dementia, and its presence is associated with BPSD. Is the patient constipated? Are they having problems with urinary retention? These are all things we can assess and intervene in and potentially ameliorate symptoms. So next we want to make sure to ask the caregivers about a history of psychiatric disorders, as these can certainly cause or contribute to these types of symptoms when they're not treated. We want to make sure to ask about psychotic, mood, anxiety, and post-traumatic stress disorders, and whether or not the patient may be using alcohol, cannabis, abusing non-prescribed medications, or other illicit drugs. Next is to create a baseline of assessment of the symptoms. It's crucially important to get this down so that we can later assess the effects of treatment and see if we're making a difference. There are many standardized instruments that clinicians can use, such as the NPI, the Neuropsychiatric Inventory, or the Behavioral Pathology and Alzheimer's Disease, the BEHAVE-AD scale, or the Cohen-Mansfield Agitation Inventory, which specifically evaluates agitated behaviors only. But these are, while they're gold standards, they're quite time-consuming, and it's reasonable in clinical practice just to get the caregivers to be specific about the behaviors and to rate on a scale of 1 to 10, say how severe the symptom is and how distressing it is to the caregiver. Next, we move on to the physical exam, and the physical exam is primarily to identify factors that may contribute to or cause the behavioral symptoms we're seeing. So, for example, signs like altered consciousness may point towards delirium or grimacing to pain. And then there are specific physical findings such as fever, hypoxia, fluid overload, inflammation that may give us a clue as to specific medical etiologies that need to be further investigated and treated. If there are acute or subacute onset symptoms, I think this should also prompt basic laboratory and radiographic exams, including a CBC, electrolytes, liver and kidney function tests, urinalysis, thyroid tests, toxicology, and a head CT, and also if prompted by the patient's history and specific findings on the physical exam. And of course, once we've gathered all this information, we want to treat any contributing medical, neurologic, psychiatric disorders, remove any offending medications, before we assume that this is just due to the patient's dementia. Okay, so we've either ruled out or treated any medical or psychiatric problems or medication side effects that could be causing or contributing to these behaviors, and they're still going on for the patient. And we diagnose that this is indeed BPSD, or behavioral and psychological symptoms of the dementia itself. Let's go on to talk about treatment now. And I want to first describe a kind of sequential approach to treating patients with BPSD. And the first, as I alluded to before, is to choose an appropriate setting. Can this be safely managed as an outpatient, or are the behaviors frankly dangerous or so severe that they need to be addressed in an inpatient setting? Second, always treat discomfort or pain in the patient. And third, we want to always implement non-pharmacologic interventions first, as these can often be the most efficacious way of dealing with these symptoms. I'm not going to talk about these right now, as we're going to address them in another lecture in this series. But I want to stress that these are really the first line treatments for BPSD. However, if they are not working and the symptoms remain, and we decide ultimately that a trial of medication is warranted, we want to conduct systematic trials of evidence-based pharmacologic therapies. And I'm going to spend the rest of the talk going through those and reviewing the data for each type of medication class. So, although psychotropic medications are frequently used in patients with BPSD, the benefits are typically quite modest, and we've learned that the side effect burden and risks turn out to be quite high. Many symptoms, such as wandering and vocalizations, are unlikely to respond to any pharmacologic therapies. And when we talk about BPSD trials, we have to acknowledge that the primary focus of clinical trials has been specifically on agitation, aggression, and psychosis, particularly in Alzheimer's disease. So let's start by talking about the use of antipsychotics or neuroleptic medications for the treatment of BPSD. This class of medication had really been the mainstay of treatment for BPSD until clinicians became increasingly aware of the particular risks of using these medications in this group of patients. This started to be increasingly known in the early 2000s when the FDA issued a warning specifically for risperidone in older patients with memory loss and found that there was an increased risk of so-called cerebrovascular adverse events, including stroke, in this group of patients. Subsequent analyses found that the risk of stroke was, in fact, higher when patients were taking higher dose of medications, when they were older age, when they had comorbid atrial fibrillation, or when they had vascular dementia in particular. And this warning was later extended to all the second-generation atypical antipsychotics and typical antipsychotics. The risk was really the same amongst the agents. And then in 2004, the FDA actually issued a so-called black box warning for increased all-cause mortality in patients taking atypical antipsychotics who also had dementia. And the absolute risk difference was about an increase of about 1 to 2%, so a significant increase. The FDA ultimately added typicals to the black box warning in 2008, and subsequent reviews have suggested that the risk of death is actually fairly similar for both typicals and atypicals in older patients with memory loss. So some very particular and serious risks when we use these medications in this group of patients. In addition to these risks, we know that elderly patients with dementia are at higher risk for extrapyramidal symptoms, gait disturbances, excess somnolence, respiratory infections, lower extremity edema, urinary tract infections, and even additional cognitive decline. In addition to the expected risks of these medications, including increased risk of metabolic syndrome, QT prolongation, and orthostasis. And I'd like to point out, in particular etiologies of dementia, including dementia with Lewy bodies and the dementia of Parkinson's disease, antipsychotics have a particular potential to worsen both motor symptoms of these disorders and the behavioral symptoms. So we want to be very careful about using antipsychotics, particularly high-potency antipsychotics, in patients with Lewy body dementia or the dementia of Parkinson's disease. So understanding the particular risks of using these medications in this population, the next question is, how effective are they? Many authors questioned whether or not they even worked, and certainly whether or not they worked well enough to justify the risks in this population. So let's talk about the atypical antipsychotics in particular, and I'm going to refer you to this classic meta-analysis done by Schneider and colleagues in 2006 of atypical antipsychotics in the BPSD of Alzheimer's disease. They looked at 15 high-quality randomized controlled trials of atypicals for agitation and or psychosis, primarily in patients with Alzheimer's disease. They looked at 3 with aripiprazole, 4 with olanzapine, 4 studies with risperidone, and 1 study with olanzapine versus risperidone, and 3 with quetiapine. The studies included both nursing home patients and community dwelling patients. As I said, they're mostly patients with Alzheimer's disease, more likely to be female, and were older with a mean age of 81. The authors found that when they combined data for the individual drugs, psychosis scores in particular, again, not agitation or aggression, improved only with risperidone and none of the other agents. Interestingly, global scores, global neuropsychiatric scores improved modestly with both risperidone and aripiprazole. The authors found that the effect of antipsychotics tended to be better in patients who were more severe, had more severe stages of dementia, more severe cognitive decline, tended to be more likely to be institutionalized in a nursing home, and interestingly, did not have psychosis. It was primarily agitation or aggression. The authors did not find that olanzapine or quetiapine had significant effect on symptoms. Subsequent reviews tended to shore up the findings of Schneider and colleagues on their review, although certainly not all. But later systematic reviews by Ballard and Waite, Sink and colleagues, showed that risperidone, sometimes olanzapine, and aripiprazole have modest efficacy for aggression and overall agitation. A meta-analysis done by Chung and colleagues in 2011 of 5 RCTs showed that there was statistical benefit of quetiapine on both the NPI and the CGI, the clinical global impression of change, but questioned whether it was actually clinically significant. Tampi and colleagues in 2016 did a meta-analysis of atypical antipsychotics for BPSD, looking at 16 studies, and again showed that risperidone, olanzapine, and aripiprazole had modest efficacy when treating psychosis, agitation, and aggression of dementia. Again, quetiapine seemed to have limited efficacy, and drugs seemed to work better when patients were in more severe stages of the disease. To summarize what we know about atypical antipsychotics, when non-pharmacologic or other treatments fail and or behaviors are dangerous to the patient and others, we believe that risperidone and aripiprazole and olanzapine have a modest effect at best. And quetiapine has a statistically significant but perhaps clinically limited effect. We know it's more effective when patients are in advanced stages, living in nursing homes, and when there's an absence of comorbid psychosis. And of course, using these drugs with their modest effects is limited by the known adverse effects that we see in all patients taking antipsychotics, and of course the particular risks, including stroke and even death in older patients with dementia. So certainly using these drugs calls for very careful weighing of the risks and benefits, and frank discussion with caregivers and loved ones. How about typical antipsychotics, the older antipsychotics like haloperidol, etc.? Ballard and colleagues did a study of typical antipsychotics in Alzheimer's disease back in 2009, where they looked at 11 RCTs ranging from 4 to 12 weeks, and with good outcome defined as a 30% improvement on standard rating scales. Well, they found that typical antipsychotics had at best a modest advantage over placebo. 4 of the studies they looked at were particularly with haloperidol. And interestingly, there was significant improvement in the sub-symptom domain of aggression with haloperidol versus placebo, but no significant improvement with drugs in the other domains of agitation. So interestingly, typical antipsychotics, which carry essentially the same risks as the atypicals, are, as we know, more likely to cause extrapyramidal symptoms relative to atypicals, and at best have a modest effect, particularly on the domain of aggression. Okay, how about cognitive enhancers? These are the class of medications that we give our patients with dementia to help slow the decline of cognitive problems and functional problems. So perhaps they might have an effect on these symptoms as well. acetylcholinesterase inhibitors are first-line treatments for mild to moderate AD. And in Rhoda and colleagues' meta-analysis from 2009, they looked at 14 randomized controlled trials of cholinesterase inhibitors. These included 9 donepezil, 3 with galantamine, and 2 with ribostigmine. The median length was 24 weeks. Unfortunately, though, only 4 of these studies were specifically designed to assess behavioral outcomes. These were largely studies more focused on cognition and function. 3 of the studies did find a significant but very small difference in total NPI. Maidment and colleagues did a meta-analysis in 2008 of memantine, which is an NMDA receptor antagonist, also in the class of medication known as cognitive enhancers. They looked at 6 randomized parallel group double-blind studies, and 5 of 6 of these had NPI outcome data. They reported a very small effect size with an unclear clinical effect, and this was not replicated in subsequent studies. So unfortunately, although some studies do show some mild effect with cholinesterase inhibitors, most of the studies were not designed to study behavioral outcomes, and there's really not enough evidence to support using cognitive enhancers as a primary treatment of BPSD, with the exception, the notable exception of BPSD in Lewy body dementia, where cholinesterase inhibitors in particular have been shown to be effective and probably the first-line treatment for those symptoms, particularly in Lewy body dementia. Next, let's talk about mood stabilizers. This class of medication, which traditionally is used to treat bipolar disorder, has been widely used empirically in BPSD. But what's the evidence base like? Lonergan and colleagues did a Cochrane review, a meta-analysis in 2009, specifically of valproic acid or Depakote. They found 3 good quality RCTs of Depakote, and but only included 2 of those in the meta-analysis. They found that valproate was actually ineffective in treating agitation and was associated with an unacceptable rate of adverse effects in their analysis. In 2008, Konovalov and colleagues did a literature review of carbamazepine and valproic acid, and they looked at 7 RCTs total, 2 with carbamazepine and 5 with Depakote. Only 1 study showed improvement. That study was with the carbamazepine. 5 showed no difference, and 1 actually showed worsening. That was with the valproic acid. And the majority showed more frequent adverse effects in medication groups compared to placebo. A later review of efficacy of mood stabilizers in BPSD by Ye and colleagues found that the most robust data in all of the mood stabilizers was actually with carbamazepine. Some evidence, but much less strong, for gabapentin, topiramate, and lamotrigine. And they found low or no evidence for lithium, valproic acid, and oxcarbazepine. Kim and colleagues did a review of gabapentin. Unfortunately, not a lot of great studies of gabapentin in BPSD, but they did find 11 case reports, 3 case series, and 1 retrospective chart review. And in their review, they found that gabapentin was largely well tolerated and effective. So, not great quality studies, but reasonably effective. So you can take that for what it's worth. In summary, for mood stabilizers, they may be individually beneficial for some patients or for aiding you in perhaps reducing neuroleptic dose or some other medication. But the evidence for efficacy and safety and tolerability is inconsistent and unproven. And we know that patients with dementia are more susceptible to the cognitive adverse effects of mood stabilizers like valproic acid. So let's move on to antidepressants as a class. Selective serotonin reuptake inhibitors, SSRIs, have been studied fairly extensively for BPSD with some conflicting evidence. To start with, let's look at trazodone, a medication that we commonly give to people for sleep rather than depression. But Martin and Torres did a meta-analysis in 2004 where they included 2 studies with 104 subjects, 16 and 6-week durations, with trazodone doses ranging from 50 to 300. And they found that there was actually no benefit for behavior, cognition, or function with active drug. And also no difference for side effects or adverse events. Seitz and colleagues did a systematic review in 2011 looking at antidepressants compared to either placebo or some other comparator medication. They included 9 studies total. 5 were randomized controlled trials of SSRIs versus placebo, and the others were trazodone versus placebo or haloperidol. Of the 9 studies, 2 studies showed reduction in agitation, specifically with citalopram or sertraline. There were a few other differences found with active treatment. They concluded that SSRIs and trazodone were tolerated reasonably well compared to placebo or antipsychotics, and showed these 2 studies that had some benefit on agitation with citalopram and sertraline. Henry and colleagues did a review in 2011 with a lot more trials in it, 19 placebo-controlled trials, and 11 of those showed benefit in BPSD, 8 with SSRIs and 3 using trazodone, and the drug was well tolerated in 14 of the 19 trials. So clearly some signal of benefit in some, but not all, of these studies with SSRIs. More recently, Porsteinson and colleagues published the results of the CITAD study in JAMA in 2014. This was a large randomized controlled trial of 186 subjects from 8 academic centers, where they looked at psychosocial intervention plus citalopram or the psychosocial intervention plus placebo in patients with BPSD over the course of 9 weeks. And interestingly, they found that there was a significant reduction in both agitation and caregiver distress in the citalopram arm of the study. No improvements on scales of ADLs or on the use of rescue lorazepam, though. And they did see a worsening of some aspects of cognition and also prolongation of the QT interval on EKG in the citalopram arm, which isn't surprising as they used a study dose of 30 milligrams of citalopram. Subsequently, there studies of antidepressants in specifically patients with frontotemporal dementia and BPSD have yielded contradictory results, kind of unclear findings. And interestingly, it seems that antidepressants are more helpful in the BPSD of Alzheimer's disease, but not so much in the BPSD of vascular dementia. And it seems that patients with Lewy body dementia tolerate antidepressants less well than those with Alzheimer's disease. So to summarize, there's clearly some evidence to support the use of certain antidepressants in BPSD, particularly the BPSD of Alzheimer's disease. The efficacy and tolerability may differ by the dementia type, as I alluded to, with less clear signals coming with people with FTD, vascular dementia, and Lewy body dementia with BPSD. Let's move on to benzodiazepines as a class of medications now. We frequently see these medications used in the community in patients with BPSD, but in general we prefer to avoid using these medications in our elderly patients, as we know that they're associated with increased risk of falls, cognitive problems, and increased risk of delirium. But what does the data say? Tampi and Tampi did a systematic review in 2014 where they looked at 5 RCTs looking at benzodiazepines versus either an antipsychotic, an antihistamine, another benzodiazepine, or versus IM olanzapine and placebo in the treatment of BPSD. And they found that there was actually no difference in efficacy between active drug in 4 of those 5 studies. One study showed that thioridazine, unsurprisingly, may have better efficacy than diazepam, and one study showed that active drugs had greater efficacy than placebo. They didn't find any difference in tolerability between the active drugs. So as far as benzodiazepines go, the available data, although limited, does not support the routine use of these medications in BPSD, particularly in light of the known risks of using these medications in older patients. They may be a backup in some clinical contexts, but should probably be a last resort. Okay, how about melatonin? This is a medication that we often give to people to help regulate the sleep-wake cycle and improve insomnia in the short term. Jansen and colleagues did a systematic review of melatonin for BPSD in 2006, where they included 5 studies, and 2 of those showed an improvement in behavioral and affective symptoms in meta-analyses of the NPI at a dose of 2.5 milligrams at 7 weeks, and on the ADAS non-cog at 3 milligrams at 4 weeks' time. There was no effect on the NPI at higher doses, at a dose of 10 milligrams. And interestingly, the effects were lost on the behavioral symptoms at 1 year for subjects who stayed on melatonin, and their mood also seemed to worsen. So melatonin may be helpful at low doses in the short term. So one interesting avenue of treatment may actually be alpha blockers, alpha adrenoreceptor antagonists that we typically give to patients either for blood pressure or prostate problems, may actually have effect on BPSD. Lucy Wang and colleagues did a small pilot study in 2009 where they looked at prazosin from a dose of 1 to 6 milligrams with a mean dose of 5.7, and found that there was actually a significant benefit on both the NPI and the BPRS. And importantly, adverse effects and blood pressure changes were similar between the groups. So prazosin may be helpful. Larger studies are needed to validate this, but certainly an interesting avenue of research. So we've talked about a number of classes for medications for BPSD, including antipsychotics, cognitive enhancers, antidepressants, benzodiazepines, melatonin, and even alpha blockers. But let's try to sort of pull it all together to describe a sequential treatment algorithm for BPSD in patients who don't respond to non-pharmacologic interventions. I adapted this from a paper by Davies and colleagues from 2018. And it describes a stepwise approach to a medication approach to these troubling symptoms. Step 1 recommends starting with risperidone at a dose of 0.25 to 0.5 per day for a 21-day trial. We start with risperidone because it does have the strongest randomized controlled trial evidence for agitation and aggression in Alzheimer's, vascular, and mixed dementias. And interestingly, is also the only approved agent for BPSD in both Canada and the UK. If that doesn't work, recommend starting either aripiprazole at a dose of 2.5 with a target of 10, or quetiapine at 12.5 to 25 with a target of 50 to 100. With aripiprazole, there's a more limited evidence base compared to risperidone, but a novel mechanism of action. So if risperidone doesn't work or isn't tolerated, aripiprazole may be a good next step. Quetiapine, the evidence base relies on meta-analyses only for evidence of efficacy, but seems to be generally well tolerated at the target doses described here. Step 3, cycle through steps 1 and 2 until all agents have been tried and are either helpful or partially helpful or fail. Step 4, evidence from the CITAD study guides us to try citalopram, suggesting a starting dose of 10. As I said, citalopram shown to be effective in large randomized controlled trial at a dose of 30 milligrams. This intervention, of course, is limited by concerns over prolonging the QT and a time lag until it starts to be helpful. So for patients with very acute symptoms, very severe symptoms, the time it takes for this to start working may make it impractical. Step 5, gabapentin started at a dose of 200 milligrams with a target of 900 total if that doesn't work. Obviously, we need to reduce the dose if the patient has renal impairment. And the evidence base here with gabapentin, while it seems to be fairly well tolerated, the evidence base really relies only on case reports and case series. If gabapentin doesn't work, perhaps a trial of prazosin, as I described, starting at a dose of 0.5 to 1, with a target of 4 to 5 milligrams. Again, the evidence base here relies on only one small randomized controlled trial, but seem to be quite well tolerated and effective. Step 7, combine any two drugs that produced a partial response in series, or if none of these things works, perhaps ECT as a final intervention. So to sum up, the choice to use medications for BPSD and the choice of the particular agent you use are far from easy and far from clear, and the clinician has to carefully weigh the potential risks with the likely modest benefit, potential benefit of using these medications. But I hope this review will help you as you make these tough calls with your patients. I also want to say that there are common limitations amongst the studies that I talked about for each of the medication classes, and one major limitation, probably the biggest one, is that while conceptually BPSD is a term that we apply to all forms of dementia, the majority of the studies that I talked about today particularly looked at subjects with Alzheimer's disease, and thus the findings may not be generalizable to patients dealing with other forms of dementia, even though the clinical manifestations of BPSD may be exactly the same. So maybe to bring it back to the clinical example I gave you at the beginning, our 75-year-old man with Alzheimer's disease and irritability, agitation, and paranoia, let's talk about overarching prescribing guidelines as you treat patients with medications regardless of class. The first thing you want to do excuse me, is select a class that's relevant to the specific symptom domain that has the best evidence of efficacy for that domain and the highest likelihood of tolerability and safety. Your choice of agent may be influenced by a particular side effect, either to avoid that side effect or sometimes even to utilize it. With older patients, you always want to start low and go slow and avoid polypharmacy whenever possible. It's essential to frequently reassess and track patients' response with medications and to monitor for side effects and toxicity. You want to maintain the lowest effective dose for an appropriate period of time, and after an appropriate period, 4 to 6 stable months, say, try to taper the medication. So, as I said, these symptoms can be episodic, and maybe after a time, patients no longer need to be on drug treatment. So always try to taper medications after about 4 to 5 months. And finally, several trials are sometimes needed until symptoms improve, so don't give up, and that's why I hope the sort of sequential algorithm will be helpful. So I want to thank you for attending today. I hope this talk on this clinically difficult and fraught subject will be helpful for you in your work with patients. Okay,